Welcome to No Filter Doctor, where we cut through the health hype, dig into what's real, what works, and what's backed by evidence. I'm your host, Dr. AK. Let's get started. Hey everyone, welcome back. Today we're switching gears. We just spent 3 weeks talking about nutrition guidelines. Thank you for coming through that journey with me. But today I want to talk about thyroid, specifically Hashimoto's hypothyroidism. And the reason for this is because I see these two patterns that are emerging very commonly when it comes to Hashimoto's. And I think it's really important that we address this so that all of you have the knowledge that you need going into these scenarios. And then you can navigate things with your healthcare team probably a little easier with this additional knowledge. The first pattern is a very clearly perimenopausal woman is diagnosed with Hashimoto's thyroiditis, and I honestly don't know by whom, but I do know that whoever made the diagnosis is now selling them a boatload of supplements, and women are spending a ton of money every month on supplements under this diagnosis of Hashimoto's thyroiditis when really they're perimenopausal and they just need some hormones. The other one is people who do have thyroid disease, but they don't quite meet the endocrine guidelines for a definition of Hashimoto's thyroiditis, so they go untreated. I think both of these could probably be managed a little bit differently. I manage them differently. Obviously, the perimenopause patients I treat for perimenopause, but my Hashimoto's that don't quite meet the laboratory diagnosis but profound symptoms, I treat them. So I wanted to get into this a little bit. And in order to do that, we need to talk about the normal anatomy and physiology of a thyroid. We are going to talk a little bit about hormones and how the thyroid hormone develops. And we'll talk about what the thyroid does when it's working the correct way. So that way we'll better understand what happens when it's not working the correct way. When we think about thyroid hormone, we obviously think straight to the thyroid, which sits here in the front of your neck. That's not exactly how it starts. And I'm not going to try and do an anatomy lesson that I got in med school on thyroid, but you do need to know a little bit more than just the thyroid here in your neck. The first thing is the anterior pituitary gland in the brain releases what's called thyroid stimulating hormone, often abbreviated as TSH. That TSH goes to the thyroid where it activates another enzyme called thyroid peroxidase. And what thyroid peroxidase is supposed to do is it's supposed to take a molecule of thyroglobulin, which is the base substrate for thyroid hormone, and then add iodine molecules to it. So when it adds 4 iodine molecules, we call that T4. When it adds 3, we call that T3. The inactive form of thyroid hormone is the T4. It usually circulates in our body bound to a protein, but it can circulate free as well. And we want it to be inactive. We do not want T3 just freely circulating around because the thyroid hormone does so many things to so many different organ systems in our body that if all we had were these high amounts of T3 all the time, we would basically have hyperthyroidism and then have a whole other set of problems. So the T4 is the inactive form. Then what T4 does is it goes to the tissues. And then the tissues that we have, depending whether it's heart, brain, kidney, reproductive system, it then converts T4 to T3, which is the active form. And that active form has a lot of influence on a lot of different body systems. It helps control our metabolism and our basal metabolic rate. That leads into thermoregulation, whether we're hot or cold. Our heart is influenced a lot by thyroid in terms of how hard it squeezes and how fast the heart beats. When you have really, really high T3 levels, you can actually have arrhythmias. It influences our ability to think, like our neurocognition, our mood. It also has a lot of influence in the reproductive system. So with women and ovulation and menstruation, thyroid is right there along with the other female hormones. Lastly, it is a very important hormone for growth and development. So when babies are born, looking at their TSH and thyroid hormones is a part of the neonatal screen, because if they are born with hypothyroidism, they're not going to develop normally. So as you can see, the thyroid hormone is an integral hormone involved in many, many different aspects of our body. The whole system is in balance. Whenever that T4 is made, not only does it go to organs where it gets converted to T3, but it comes back to that anterior pituitary gland that we talked about, and it tells the anterior pituitary gland, hey, I'm here. You don't need to create any more TSH. I am here in good amounts. You can just kind of slow down. And then when the levels of T4 are low, that tells the anterior pituitary gland, hey, we need more TSH. Can you make more TSH? However, sometimes that system can be thrown out of whack. And that's when we start to have some thyroid issues. You can have hyperthyroidism, which is way too much thyroid hormone, or you can have hypothyroidism, which is too little thyroid hormone. And that can go wrong in a couple different places. The one is the brain. So the anterior pituitary gland, something may happen and it's just not releasing TSH the way that it's supposed to. The T4 levels are low. They're coming back and telling the brain, hey, we're really low. We need you to make TSH. But that anterior pituitary gland's like, yeah, no, I'm not going to do that. So then you get lower and lower amounts of T4 because that TSH is never released to go turn the thyroid gland on. The other area that it can go wrong is in the actual thyroid. So your brain can be doing the right thing and releasing TSH from the anterior pituitary gland, but then the thyroid is like, yeah, no, I don't feel like it. I'm not going to make any T3 or T4. No, thank you. In order to determine which area is going wrong, we typically look at labs. When we are talking about a central hypothyroidism, meaning it's coming from the brain, TSH levels and free T4 levels are going to be low. When it has to do with the thyroid, TSH levels are high and T4 is low. But here's the issue. Leaning just on lab values can be challenging because there are multiple different reasons for the TSH to be high. You could have a viral illness that can do it. You could have just had a really significant illness. Let's say you were just in the hospital, you had sepsis or something like that. That can make your TSH completely abnormal. People who suffer from obesity, they're going to have abnormal TSH levels. Our TSH levels change as we age. So you can measure these TSH levels and they're really high because of these different stressors that happened, but then measure them again later and they've gone back to normal. One study found that 46% of the patients who had a TSH of greater than 7 in their study, those values normalize on their own. I mean, that's just under 50%. Oftentimes, labs will be rechecked in order to confirm a diagnosis. The other thing that we have to consider about labs are those reference ranges. So we get blood work done, whether it's LabCorp, Quest, they have reference ranges set that are calibrated to the instruments that they're using that analyze the blood. And not everyone is going to fall within those boundaries of the reference ranges. Some people's normal might be slightly outside that reference range. And that also gets a little bit difficult. The other thing is symptoms. We have to lean into these when we are talking about thyroid disease. In fact, I would say most of the time, if I'm going to diagnose a disease state, it's usually the symptoms that drive me down that road of investigation, right? Someone comes in, they're complaining of certain symptoms, and I'm like, oh, I wonder if it could be this. And then I order labs. With thyroid, specifically hypothyroid, the symptoms are going to be everything is slowed down. You're sluggish. You're cold all the time. You don't really want to eat, but when you do eat, you gain all of this weight. You have a hard time thinking. You're really tired. Maybe you're constipated. So everything is just slow. Heart rate's slow. Temperature is usually low. And it doesn't have to be profound. it can be something very gradual that happens over time. And in some cases, you don't even notice it until suddenly you hit this threshold where you're like, holy smokes, what is going on with me? I feel like an absolute slug. Like I can barely move, barely think. I don't want to eat. I'm gaining weight. I'm bloated. I have this cognitive issue. Sounds a lot like perimenopause, right? So when you have those symptoms, you then go down the investigation of labs. And then you have to respect the fact that not everyone falls inside of these reference ranges. You could have someone with a high normal TSH and a low normal free T4, and I would argue we should probably consider treating them, even though a lot of the societal guidelines really want those lab abnormalities to exist. So that was a lot, but that was the simplified version of the anatomy, physiology, and nuance of thyroid and labs. So let's actually get into Hashimoto's now. Hashimoto's thyroiditis specifically is an autoimmune disorder. And it's where your body starts to attack the actual thyroid gland. It then causes inflammation in the thyroid. On ultrasound, you'll see some tissue changes and structure changes because of that autoimmune attack. Then the thyroid can't really make T4 and T3 the way that it's supposed to. And over time, those hormone levels drop and you start to feel a lot of those symptoms of hypothyroid that I talked about. In areas where the amount of iodine in the diet is sufficient, this is actually the most common cause of hypothyroidism. Typically, the diagnosis is made when the TSH goes up and the T4 goes down. So you have a high TSH, you have a low T4. But like I said, this gets tricky, especially with aging, because as we age, TSH goes up and T4 goes down. One of the ways to approach this when you have the question of, are these thyroid changes because they're getting older or do they have Hashimoto's, is to lean into those symptoms. We've talked about them already. But the other part of that is sometimes when you are older and you develop Hashimoto's thyroiditis, you don't have those symptoms. There was a study where they looked at patients who were 65 years of age or older and found that many of those patients had clear lab abnormalities and had some of the symptoms, but the diagnosis was missed because they didn't have all of the symptoms. It can be a very challenging diagnosis to make depending on all the other things that are going on. So you can see how some women may have perimenopause, but they're diagnosed with Hashimoto's, and how some people might have Hashimoto's and it goes missed or undiagnosed, right? So if it's one of these cases where someone's labs they're abnormal, not quite meeting the definition, and they have some symptoms but not all, I look at a couple other things. One, what's the family history? Is there a family history of Hashimoto's thyroiditis? Because that makes the likelihood of diagnosis go up significantly. Is there a family history of other autoimmune disease? Because once you have one autoimmune disease, your risks for other autoimmune diseases go up. But another one is another lab, and it's called thyroid peroxidase antibody. So you'll see it's a TPO is how it's abbreviated. And TPO is a measure of the antibody. So if your body is attacking the thyroid, you're able to measure those antibodies, and that's where TPO comes in, and it's super helpful, especially in some of these cases where it's like you have some symptoms, you have some lab abnormalities, I'm not entirely sure, but you have an autoimmune family history, or you have elevated TPO antibodies. All right, that helps me a ton. If I have a patient who's symptomatic, has a really high, abnormally high TSH, and abnormally low T4, I'm pretty comfortable making the diagnosis. This nuance that we're talking about are the people who don't quite fall within that frame. So if we go back to another patient who has some symptoms, high normal TSH, low normal T4, and now they have positive TPO antibodies, I'm going to get an ultrasound of their thyroid, and I bet you I'm going to see some structural abnormalities, and we have nailed the diagnosis of Hashimoto's thyroiditis. Here's what makes the diagnosis challenging, though. Right now, all over social media, there are all these people saying, oh, I've had Hashimoto's my whole life. All the doctors have missed it. I found this one person who has almost no medical training who made the diagnosis and put me on supplements, and I feel so much better. There's a lot to unpack there with the whole making the diagnosis. First of all, I highly doubt someone has had Hashimoto's their entire life. That's not how it develops. It's an autoimmune disease. So you need time to develop the antibodies, and you need time for those antibodies to cause enough damage that you actually have a malfunctioning thyroid. So let's start with that. Next, if you have symptoms of hypothyroidism that we talked about, right? Like feeling sluggish, low energy, you don't really want to do anything, you're really tired all the time, you're gaining weight. Those are very vague symptoms. While yes, they do align with hypothyroidism, they also align with a lot of other things, including things like poor nutrition, lack of exercise, depression. I mean, these are actual diagnoses and other things that are going on that are important and need to be addressed. And sometimes it's just easier to throw that into a diagnosis and give someone supplements or pills, and then they're like, oh, wow, look, now I'm cured. No, it's a Band-Aid. It is a Band-Aid if you are giving a bunch of exogenous agents, whether it comes in supplements or medications, for a condition when you're treating the symptoms without all the other stuff that you need to make a diagnosis. If I have a patient who feels that way, has the symptoms of hypothyroidism, but their TSH is smack in the middle of normal reference range, smack in the middle of normal for T4 as well, I am not going to make the diagnosis of hypothyroidism. Even if their TPO antibodies are present, it's still not hypothyroidism yet. You're not even at the extreme ends of those reference ranges. There's something else going on. And if I put you on medications or give you supplements or make whatever recommendations for hypothyroidism, we're not addressing the underlying issue that's actually causing the problem. So when it comes to diagnosing Hashimoto's thyroiditis, there is a pattern to do that. A normal ultrasound, normal thyroid labs, it is not Hashimoto's thyroiditis. It is going to be something else. And that something else needs to be diagnosed, and that something else needs to be treated. Okay, I'm getting off my soapbox of diagnosing Hashimoto's thyroiditis, and now we're going to talk about some of the other things like treatment and other information that's important to know. Treating Hashimoto's is really important because untreated hypothyroidism can lead to other issues down the road. Untreated hypothyroid can lead to increased LDL, and we know how I feel about keeping our LDL cholesterol levels under control. It can cause left ventricular dysfunction. It may also contribute to developing dementia, especially in patients who have had hypothyroidism and they're less than 75 years of age and it's been untreated. So we don't want any of those conditions, right? It's really important that we treat this hypothyroidism. But just like making the diagnosis isn't cut and dry, there's some issues with the treatments as well. There's a little bit of controversies and a lot of people have different feelings about this. The guidelines are pretty clear on whom to treat and how to treat them. So the American Thyroid Association and the American Association of Clinical Endocrinologists, they have both drawn a line in the sand and they said, if TSH is greater than 10, we need to treat. And we need to treat with synthetic T4. That is the Synthroid is the brand name, levothyroxine generic. That's typically what we use in the United States. If they have a TSH between the upper limit of normal and 10, and they're younger and symptomatic, treatment is also reasonable. Where we're not entirely sure is patients who are older than 70 and have a mild TSH elevation. Now, TSH, as you get older, normal becomes higher and higher. So in that population, if they have a mildly elevated TSH, we may actually not need to do anything. This may be just a part of aging. The TRUST trial investigated using Synthroid in elderly patients with higher TSH levels, and they found absolutely no benefit in giving this patient population synthetic T4. It did not improve fatigue, cognition, strength, or cholesterol. It didn't do anything. So in those older populations, we also monitor. We just wait, watch, and see what's going on with them. Where treatment options go off the rails is with supplements. There's a lot of, especially on social media, things like the thyroid healing protocol that you can buy for $500. That's not what is going to help you. There are some supplements that are out there that might actually help, and those are the ones that I'm going to talk about. Everything else I think is pretty bogus, and I know that is a very strong claim, but I'm going to claim it because I looked at the evidence, and other than the three that we're going to talk about, there is not a whole lot of support out there in terms of scientific data. The first one we're going to talk about is selenium. There was a study done that looked at patients with elevated TPO antibodies that were treated with 83 micrograms of selenium methionine, and they found that at about the 4-month mark, half of those participants had reduced levels of TPO antibodies. And when they continued this supplementation beyond 6 months, it pushed it closer to 83% of those patients had lower TPO antibodies. And so the thought is, if you lower the antibodies, then you are lowering that level of attack on the thyroid, and that can improve the Hashimoto's thyroiditis because you're taking care of the antibody bit of it. So selenium is something that can help with Hashimoto's thyroiditis. Another supplement that may help is vitamin D. It may reduce TPO antibodies as well. There is a study that showed when you take vitamin D at the 6-month mark, your TPO antibodies go down. But in that one, they weren't able to establish as much of an argument with the clinical significance. That's okay, it's still on the list. Vitamin D is not a bad supplement to take. In fact, most of us are probably deficient in it. There was another study that looked at the combination of myo-inositol and selenium, and they found that in patients who had subclinical symptoms, they had an improved TSH and antibody levels. But I'm going to say these studies were really, really small, and the outcomes were teeny, tiny, trending positive. So we probably need some more studies in this myo-inositol selenium combo to see, is it truly that helpful? These supplements weren't like, yes, definitely do it, but at the same time, there was no harm associated with it. If there's no harm, I'm okay with it. It's the things that we have no idea if they're safe or not, and people are taking them left and right. Those are the ones that I'm like, pump the brakes, folks. Here's the thing though, you don't have to take the supplements. You can actually get these molecules in the foods that you eat. Iodine-containing foods are helpful. Things like seafood and dairy and eggs. Selenium can also be found in foods. You don't have to take the supplement. It's things like Brazil nuts, sardines, tuna, eggs, and cereals. I do want to stress one thing though. You can develop toxicity from too much selenium. It is an essential mineral. It is something that we need in our bodies, but too much of it is bad and you can develop a toxicity. So you can't take selenium supplements and then go gobble up selenium-rich foods. When it comes to vitamin D, you can take a vitamin D supplement, but you can also get it by going out in the sun. Wear sunscreen, please. But going out into the sun, that's actually the highest source of natural vitamin D for us. There's also a bunch of foods that either naturally or through fortification contain vitamin D. These are things like cod liver oil, a lot of other oily fishes like mackerel, salmon, tuna, egg yolk, and then those fortified foods are things like breakfast grains, milk, yogurt, orange juice, and soy, actually. A lot of the wellness people are like, oh, you should have a gluten-free or dairy-free diet if you have Hashimoto's thyroiditis. Unless you have celiac disease or a documented sensitivity, there's no evidence to support that. In fact, most evidence of the anti-inflammatory diets point to a Mediterranean diet. And you can go back and listen to the Inflammatory Diet podcast or read the Inflammatory Diet blog if you want more information about that. The whole getting rid of gluten or getting rid of dairy, that has not been proven in any of the studies that I've looked at. And yes, this is nutrition science. And yes, we know these are observational studies. And yes, the data is not rock solid, but there aren't even things that I found that are trending in that direction. So I don't think you have to cut out those aspects of your diet because of this. You can do it for other reasons, but with Hashimoto's, it's not going to help. When we put all of this together, what does it mean? Well, a couple things. First of all, there are a lot of people being told they have thyroid issues when they do not have thyroid issues. TSH levels fluctuate. Vague symptoms can be due to all kinds of different things that are completely unrelated to your thyroid. So when you have someone telling you, hey, this is your thyroid, and they're trying to shove a bunch of supplements down your throat, I think that's a red flag. You need to take a step back and say, well, what are these supplements? Are they any of the three that we just talked about? How much are they? How much money is this person going to make if I buy all of this stuff from them? You have to always be skeptical when there is some financial motivation behind anything. There might be other things going on in your life, like sleep deprivation, lack of exercise. Maybe you're overworked. Maybe you are nutrient deficient in other nutrients. I mean, all of these things can contribute to those vague symptoms that are often blamed on hypothyroidism. It's really important that we get the diagnosis right and we fix the underlying problem. If you happen to have some of the symptoms that we talked about today, some of those vague symptoms that you can't quite explain, but you're like, oh, I don't feel so great, the first thing you need to do is go talk to your doctor. They are going to know which labs to order. They know about TPO antibodies. They know about an ultrasound. They know all those things. Have that conversation with them. When they get these tests, if everything is completely normal, I'm not talking about high normal TSH, low normal T4. I'm talking about your lab values fall right in the middle of those reference ranges. It's not going to be Hashimoto's thyroiditis. There's something else going on, and that is what needs to be diagnosed so that you can get better. I hope you found the conversation today helpful. I hope you now have a little bit more knowledge so that when you are engaging with some of this social media medical fact, you know how to approach it a little bit better. Thank you so much for joining me on this week's No Filter Doctor. If you enjoyed the content, you can follow me on social media. I'm on Instagram, Facebook, and YouTube. You can also go to www.thewholehumanhealthandwellbeing.com and sign up for the weekly newsletter where you will get a link to the blog, that week's podcast, and a health tip of the week sent directly to you. It's important to know that while I am a doctor, I'm not your doctor. This podcast is for educational and informational purposes only, and it's not intended as medical advice. Listening to this podcast does not establish a doctor-patient relationship. The information discussed should not be used to diagnose, treat, or prevent any medical condition, nor should it replace individualized medical care. If you have questions or concerns about your health, please contact your own healthcare provider. Any decisions to delay or forego a medical evaluation or treatment based on the information discussed in this podcast are made so at your own risk. My only financial disclosure is my medical practice, The Whole Human Health and Wellbeing. Take care, and I'll talk to you next week.